Good afternoon, everyone. Welcome to our Addressing Food Safety Challenges in Correctional Facilities webinar. Looks like folks are still joining, so we'll give it a few more minutes. Looks like folks are still joining, but we do have a packed agenda today with some really great speakers. So for interest of time, let's go ahead and get started. So good afternoon, everyone. We are very excited to have you join us today on our last webinar of a three-part Integrated Food Safety Centers of Excellence series, focusing on food safety in correctional facilities. My name is Amanda Tran, and I'm with the Colorado Integrated Food Safety Center of Excellence, or the Food Safety COE for short. We are one of 5 food safety COEs located across the country with the mission of providing peer assistance, resources, and trainings to support state and local health departments build their capacity to track and investigate enteric diseases. And the topic of today's webinar is addressing foodborne illness and outbreak investigation challenges in correction settings. And we have 3 subject matter experts joining us today from Washington, Minnesota, and the Federal Bureau of Prisons. And they'll be sharing their expertise on this topic. But before we get started, I just wanted to briefly go over a few housekeeping items. So first, this Zoom meeting is set up in webinar mode, so you'll only be able to see and hear the presenters. If you have any questions for the presenters, please go ahead and add them to the Q&A feature or in our chat box, and we'll answer as many as we can there or at the end of the webinar during the Q&A session. And second, if you would like to view a live transcription of the webinar, we do have that capability. If you go ahead and click on the show captions button on the toolbar on the bottom of the resume window, that live transcription should pop up for you. And lastly, if you're not able to stay for the entire webinar or would like to rewatch it at some point, we will have a recording of this webinar as well as the 2 previous webinars on the same page that you used to register. And so with that, let's go ahead and get to the presentations. So it's my pleasure to introduce our first speaker for today, Luann Buck. So Luann has been with the Minnesota Department of Health for close to 3 years as a corrections system planner in the Infectious Disease Equity Engagement Unit in MDH's Infectious Disease Epidemiology Prevention and Control Division. And prior to coming to the Minnesota Department of Health, she has had 30 years of experience in community reentry programs and 20 years leading and managing residential community corrections facilities, also known as halfway houses, electronic home monitoring, drug testing, and substance use disorder programs. And with that, I will hand it over to you, Lynn. Nope, I think you are still on mute.
Sorry about that.
Oh, yes.
Share my screen. And let's see. I had this earlier, so there we go. Can you see that? My screen. Okay. Can you see my slides? No?
I don't see anything yet.
Yeah, we're not seeing them.
Okay, let me go back. That is not working. Okay. I had it earlier. Sorry about that. Okay. I don't know what is happening.
I can go ahead and share the slides for you if
Let's see.
that would be easier.
Yeah, I think so.
Okay.
To save time, for sure. Thank
Let
you.
me pull up your slides. All right, so let's see. Yeah.
Okay.
Okay.
All right, great. Thank you. Will I have notes with that too, Amanda?
No, not on my screen.
Okay. Okay, so, well, thank you. I'm sorry for that, folks. My name is Luann Buck, and I am from the Department of Health in Minnesota. I'm hired as a correction systems planner in the Infectious Disease Equity and Engagement Unit. And I was hired into a COVID-19 grant to support our corrections folks and MDH. So next slide, please. I'm going to give you a really high level of the criminal legal system. So this is kind of a really simplified way, linear way of how people flow through the correctional system, from when they enter by committing a crime, through the prosecution, court process, corrections, until they're released back into the community. In Minnesota, we call it supervised release, but in other jurisdictions, they may call it parole. So next slide, please. And this is really how people kind of generally go through the criminal justice or criminal legal system. It's not as linear as in the previous slide. People generally are arrested. They might get released right away, or they may stay in jail until they have a preliminary hearing, or they go for an arraignment. They might plead guilty. They might not go directly to jail. So you could see how this can be disruptive for people who are involved in the criminal legal system and their families. Next slide, please. And our IDEPC division has a preferred language guide for many of the people who are on the margins, including people in corrections. And so really generally when talking about folks who are involved in the criminal legal system, use their name rather than a label, rather than using offender, call them an incarcerated person or a person who has committed a crime. Rather than using a detained person, use a detainee. Don't use detainee, but a person who is detained. And also for correctional officers, use correctional officer rather than guard, because correctional officers generally do more than just guard. So they are trained in de-escalation techniques and report writing. They might pass medications and those types of things. And they really are part of the law enforcement community, but on the inside. Next slide, please. And the general differences between correctional facilities, people who are convicted of felonies are generally under state or federal jurisdiction, and their length of stay is more than a year. Jails generally have people who are on pretrial status or convicted of a misdemeanor and are in the jail for less than a year. And then under community supervision, it can be under federal, state, local control, and the person it's in lieu of or post-conviction, and the length of being on community supervision will vary. Next slide, please. So this illustration from the Prison Policy Initiative is kind of shows the mass incarceration in the United States. So the United States really incarcerates the most people in the world. And there are about 583 people per 100,000 residents who are incarcerated at any given time. Next slide, please. And so really incarceration is a public health issue. So as you can see on the slide, nearly 6.9 million are either on probation, in jail or in prison in the United States. And compared with other individuals who have not been incarcerated, um, significantly higher rates of communicable diseases, chronic conditions, mental health conditions, and now we know 6 times more likely to have a foodborne illness. Next slide, please. So engaging with partners. During the COVID-19 pandemic, the Department of Health created a highly impacted settings team to work with jails and with shelters. And so what they really did during the height of the pandemic, they did, um, screening and testing and provided PPE and guidance to our corrections partners and our healthcare, or I'm sorry, our homeless shelters. Next slide, please. So this really shows the really wonderful work that the highly impacted settings team did by distributing PPE masks, testing kits, contracts, vaccine clinics, therapeutic navigator service, and funding and emergency staffing. So I am privileged to work alongside with this team and continuing the work. Next slide, please. So these are some of the engagement activities that we have been involved in since the height of the pandemic. We've done some surveys, we're doing some collaboratives, attending conferences, and working in the community. Next slide, please. So after the height of the pandemic, we sent out a COVID-19 survey in February of 2023 because we really wanted to understand how the response to the pandemic that the jails felt, how we did during the response, how they did during the response, and what were some challenges that they were going to face in the future with other pandemics that may come on down the line. And so, as you can see, one of the greatest challenges for our partners were adhering to guidelines from outsiders that really don't have any correctional experience in not understanding what they do. And so, from an engagement perspective, we really want to know how to communicate better with this and reach out to them in helping us do the guidance. We've also since done our epidemiologists in the highly impacted settings team assisted in a data analysis for jail nurses that they submitted. The Minnesota Sheriff's Association Correctional Health Division nurses sent to jails throughout the state, trying to understand really what the nurses were doing in the facilities and the number of FTEs that they needed to do good correctional health care. I'm not sure that they really got down to the answer to that question, and so more work is being done around that. And our current engagement activity is to do a jail infectious disease health system assessment. And it's really a survey that we learned about actually from our Arizona Department of Health partners. And, ours is a little bit different, but for us, it's another area to strengthen MDH capacity to work with jails to protect and promote health among staff and detained people. And so we are currently in the process of a survey development team, primarily made of correctional health nurses, some jail administrators, Department of Corrections Inspection and Enforcement Unit, which licenses and inspects jails in Minnesota, to help us develop the questions and before we send out the survey, which we're hoping to send out in March. Next slide, please. And also as a result of some of our survey activities, we wanted to do better in continuing dialogues with our correctional health partners. So we established what's called a Corrections Public Health Committee of approximately 20 correctional health nurses and a smattering of jail administrators throughout the state. But we felt now, after a year of meeting, that we wanted to open it up to more community partners and correctional health staff. And so we will be doing maybe a larger forum, which also then led us to our internal correctional health collaborative that you see at the bottom. And that purpose is really to build relationships across MDH. We're so siloed, we don't know what each other is doing. So we really want to amplify our shared vision and increase health for all Minnesota, and present ourselves as a united MDH to our partners. And our highly impacted settings team sit on meetings at the National Peer Network for Corrections that sustain our next presenter co-leads with CDC. And that just is to learn from and share programmatic work and to identify opportunities to collaborate across the states. Next slide, please. And part of my function too is when I came to my position, I knew of some conferences that I had previously attended, and MDH was not at the table. So I attend the Minnesota Sheriff's Association Jail Admin Conference, as well as their Correctional Health Division Conference, and Minnesota Department of Corrections, or MCA Conference, just as a vendor to provide resources and network with our jail partners and other folks that work with the jails and the prisons in the state. One of my favorite activities to do is to attend the Minnesota Department of Corrections Transitions Fairs. So we have 11 prisons in the state of Minnesota, and 9 of them put on transitions fairs annually. And it's an opportunity to meet incarcerated people who are going to be released to the community within about a year, and provide them with public health information and education. And so that includes not just infectious disease information, but harm reduction, where people can find Narcan and testing strips for fentanyl and xylazine, and those types of resources. And I also have attended some reentry programs that are led by formerly incarcerated folks, just as another way to build trust with people who are living in the community. And next slide, please. And other considerations, jails might be short-staffed in both security and health services. Please use plain language whenever possible when doing any investigations. Bring resources, guidance, tip sheets, sick logs, etc. When I was a director of a halfway house and being inspected by our either the city or our state public health departments, it was always helpful to say, hey, I don't have a sick log for norovirus. I don't know what that is. Can you send me one? And they were always really great in sending something back to me right away. And then certainly find peers in your public health organization who are currently or have worked with corrections in the past. And also understand that some jails and prisons also contract for their food service and their healthcare services. Next slide, please. And that's really the end of my presentation. Thank you. Feel free to reach out to me. My contact information is on the slide.
Thanks, Joanne. Yeah, thanks for providing the great overview of the criminal legal system and Minnesota's engagement activities. Really great work there. And if you have any questions for Luann, just please go ahead and add those now to the Q&A box, and we'll get to them at the end of the webinar. And our next presenter today is Sistine Curry. 16 is Washington State Department of Health's inaugural carceral health epidemiologist, and has been building partnerships with Washington's prisons, jail association, and juvenile detection facilities since the start of the COVID-19 pandemic. And she has recently secured funding to expand her work in a more cross-cutting capacity across communicable diseases, including co-leading and co-founding the Carceral Public Health Peer Network that Luann had just mentioned. Carceral Public Health Peer Network. It's a national group that unites public health staff to discuss emerging issues, share resources, and learn from each other to improve health outcomes for people in carceral facilities across jurisdictions. And with that, I will pass it over to you, Sistine.
All right. Hi, everyone. I'm going to get my screen set up real quick. All right, just wanted confirmation that you are seeing the right screen.
Yes, we can see
All right, great. Okay, so hi, everyone. As Amanda said, I'm Sistine Guri, and today I'm going to talk about building public health partnerships with carceral settings. So I wanted to start us off with kind of two grounding statements. And the first one, which I think Luann did a good job kind of highlighting, is that carceral settings have high public health needs, but few public health resources. And the second one, I think, gets at the fact that even though public health does a lot of work in these settings, I think public health can do better at supporting carceral settings with their public health needs. And these two statements are important to kind of acknowledge upfront because carceral health is community health. And 95% of people who go to prison will return to their communities. And everyone who goes to jail but doesn't go to prison does come back to their community. And then there are staff who work in these settings and they also live in the community. So this is our community's health. And I think this article in The Lancet that was published a couple weeks ago really does kind of sum it up nice, saying that incarceration is an indicator of our community's health. And I bring this to you all as this way to kind of challenge the idea that this setting, this population, the work that's done here is separate from our public health work or the primary public health work. And that we can do a better job at bringing this into the fold by starting to build stronger partnerships with our carceral settings in our own jurisdictions. So today what I'm going to talk about is a quick little case study of how Washington State Department of Health is doing this work. I think we saw a great example in Minnesota. So this is Washington's version. And I'll talk about kind of the limitations of what we saw as our current kind of approach to working with carceral settings and how COVID-19 brought together this opportunity for a newer model that we're trying to bring into this new era. And I'll share some kind of lessons learned and a kind of future vision for what I call carceral public health. I think there's a bunch of us that call it that, to what this kind of work would look like beyond a pandemic. So I always think it's fun to understand what each state is working with when they present. So for us, like Washington has 97 carceral facilities, and that is represented by 2 federal facilities, 1 ICE facility, 1 Bureau of Prison. We have 12 state-run prisons, 12 reentry centers or halfway houses. And those are those state-run ones. And then we have 58 county, city, and tribal jails. And we also have 32 juvenile detention facilities in our state, mostly run either between the state and the county, and then 1 private. And I think for many of you, if you work in government, you understand that it's typically a very siloed approach for a lot of things. And especially in public health, where a lot of the funding is based on disease. And we don't really kind of talk to each other about our projects and our work unless really they're kind of closely related. And then, I think there's a similar kind of siloed structure in carceral facilities and organizations where you kind of have custody in this one corner, you have health services in another, and occupational health, and they don't always kind of talk to each other, similar to how public health doesn't talk across their silos. And then when these 2 organizations need to talk to each other, I think what we've seen, at least in Washington, is that there really have been only kind of 2 types of instances where there is communication. The first is in an outbreak. And what that kind of looks like is probably communication between health services and that disease team in public health. And they kind of coordinate together a response. There's very little communication across the silos within the organization. If there is, great. But we saw that that was a limitation. And then, I think the other part of that was that if this was an outbreak for a new disease where health services didn't have a contact at the Department of Health, they often struggled to find who that person was, to connect with, who that epi was. And then similarly on public health side, if they identified the outbreak or the case first in this setting through their systems, they struggled as well to identify who that point of contact was because that communication wasn't constantly there. And like, for example, if the TB team does work regularly with the carceral facility, if there was another outbreak for measles, for example, or something different, there would be those similar issues of, who do I contact in this instance? And then the second type of, I guess, like touch point that we'd see between public health and carceral facilities is through disease-specific programming. And these are kind of like, very long-term types of programs. They're surveillance systems. And, I think there is a lot of communications. These are really great programs. However, they're very narrow in focus. They really only address one specific disease, but you could probably argue, for similar types of programmatic work for every condition that public health funds. But it's too narrow in focus. We're not really looking at the population health as a whole or the patient health as a whole. And so you can imagine during COVID-19, this siloed structure really just introduced a bunch of problems and really revealed the shortcomings of a siloed structure. No one was talking to each other. We needed to find a better way to coordinate. And it showed that we just didn't have a system set up to do this more collaborative work that's required. So I just wanted to highlight some limitations of this siloed approach. Really, this doesn't build partnerships or long-term trust across these two organizations. And that public health does not have expertise in carceral settings. One thing I forgot to mention is that, with a new outbreak with the new team from public health that has to work with the carceral setting, they don't have any expertise in this work. So you have to quickly learn in an emergency setting how to tailor general public guidance to this setting. And we're not set up properly to do that. And the last part is just that poor communication and collaboration within and between organization silos really just stands as a barrier between our ability to really stand up really great public health programs together. So what we did at the beginning of the pandemic was establish a carceral health epidemiologist position. This is my role. And this epidemiologist served as a liaison between silos and really kind of brought all the key players together into the room to coordinate resources, to make sure everyone's talking and at the table. And I think it really did create this kind of centralized way to work together. The way I would describe my work over the last 4 years kind of can get summed up into three main buckets of work. The first is really just focusing on partnerships, and that is talking with your prisons, your juvenile facilities, and your jail associations, just to make sure that they're getting information that's really relevant in a fast-paced emergency. And even outside of that, to make sure that they're getting information related to resources and understanding what public health programs exist. And really the partnership building piece really looked like showing up to meetings and being consistently there and answering questions or bringing back information to help these partners really get the most out of public health when they ask for it. The second pillar of work is guidance. And during the pandemic, my team, the congregate settings team, really spent time taking what CDC gave us and adapting it to our state laws and requirements. And as a result, I spent a lot of time working with our jails, our local health departments, and our prison system, providing technical assistance on how to interpret and implement these in their settings. And I think many of you will know that if you visit one prison or one jail, you've seen one prison and one jail. They really are unique settings. And so really that kind of tailored support and consultation was really important to have. and I can't stress that enough. The third piece of work is outbreak prevention and response. And I've already kind of shared a little bit of what that looks like, which is coordinating resources. As we've emerged kind of out of the pandemic, it's looking more like supporting other disease subject matter experts to make sure that, they are able to communicate when needed with our carceral settings, and making that connection so that they can work together. It's also looking like building surveillance tools, leveraging our existing data systems to more quickly identify cases associated with a carceral facility. And the other kind of group of work, which Luann kind of touched on, and you'll see mirrors some of what they're doing in Minnesota, is really organizing public health to think more holistically about what I'm calling carceral public health. And so for us, what that looked like is creating a community of practice with our local public health, for them to share the work that they're doing with each other, to build better partnerships with their jails, bringing public health programs in these settings and sharing lessons learned, challenges, and strategies on how to do this work. Similarly, for the Department of Health itself at the state level, we created a collaborative for us to break down those silos a little bit more and to be able to have visibility on what that work looks like with carceral settings at the state level, and to find opportunities to coordinate resources or communicate about those and, where we can collaborate. And then at the national level, we have that peer network that Luann and Amanda mentioned. And really that is to mirror kind of the principles of what we're doing here, which is to share ideas, share successes, and help public health do better work and build better partnerships with carceral settings in their jurisdiction. So a few lessons learned that I want to share with you all is that building trust and partnerships takes a long time. You will not get it after one meeting, but it starts by opening up lines of communication, making sure they know who you are and you know who they are. And they is, the health services lead, the lead clinicians, the jail commander, and that they know who they're talking to on the health department side. And really just being present and consistent and showing up where you're needed is really a great way to kind of start building that trust. If you're able to set up these kind of recurring meetings to check in with your carceral partners, I think leaning on listening and learning, especially if you don't have that expertise of the carceral system, is really important. And I think also assuming that there are good intentions. I think everybody I've met in the carceral system or the leaders that I work with, they want to do good work. They want to provide good healthcare in these settings, but there are lots of barriers to achieving those, such as short staffing, and other types of resources. And so just understanding that, I think helps kind of approach problems from a better place, and knowing that rules probably aren't followed in practice, because of these barriers. So it's important for public health to meet facilities with where they are. And I think with that public health guidance comes unintended consequences. And so having that someone from the public health side who does have that expertise of the carceral environment, can help kind of foresee those or talk those through and really kind of problem solve issues before they become one. And last but certainly not least, I think finding avenues to hear from people with lived experience, people who've worked in these settings. It's really important to bring everybody into the fold in order to build a stronger public health partnership with carceral settings. So I'll leave you real quick with a vision for what carceral public health would look like. And I think it starts by taking a population health approach to carceral health. And, within the public health system, having some kind of cross-cutting team or staff member who can leverage existing disease-specific expertise, and has this cultivated specialized knowledge of carceral environments can be this awesome partner to help facilitate and deliver essential public health services into these settings. And so I'm just going to leave you with that. There are a couple references and resources that I shared at the beginning, or mentioned. This Lancet article is here. And then this week, the Bureau of Justice Assistance released this guide on what public health and carceral facilities need to know about each other. And I highly recommend taking a look at that because I think it's a very useful guide. And then these are some other articles that have been published about lessons learned from the pandemic that I think apply to any kind of situation with public health in carceral settings. So with that, I'll close it off. Here's my email. If any of you are interested in joining the peer network, you can send me an email.
Great, thanks, Sistine. Really great work that you're doing there in Washington, and really needed work, and fostering those partnerships between public health and carceral settings. And if anyone has any questions for Sistine, again, please go ahead and add those to the Q&A box, and we'll get to those at the end of the session. And now I'd like to hand it over to our last presenter, Captain Mitchell Holliday. So Captain Holliday currently serves as the Chief of Nutrition and Dietetics for the Federal Bureau of Prisons. And in this role, Captain Holliday's major responsibilities include nutritional management of the Bureau of Prisons food service operations, responsible for providing meals to approximately 143,000 individuals per day, and serving as the Bureau of Prison senior subject matter expert on clinical and public health nutrition policies and guidelines. In addition to his role, the Chief of Nutrition and Dietetics for the Bureau of Prisons, in 2021, Captain Holliday was selected by the Surgeon General as the 11th Chief Dietitian Officer for the United States Public Health Service. And Captain Holliday has presented and published articles numerous times on food safety matters and corrections, and was a co-author of the recently released CDC Model Food Safety Practices for Correctional Facilities. And I'll pass it over to you.
Thank you, Amanda, and thank you for the opportunity to present here this afternoon. And for those of you listening in today or on the recording, I want to build off of the kind of the previous two presenters and narrow it down a little bit to kind of the topic today of addressing food safety challenges in correctional facilities. And then specifically, one of the things I wanted to address was the actual response to foodborne illness outbreaks, because I think through the previous two presentations, if you listened in on those or to the recordings, you have a general understanding of how complex and unique these outbreaks can be, how challenging it is in this environment in managing some of the higher risk foods in correctional facilities. And this is a really unique environment. And the research really shows, going back, I think, to the Marlowe et al. Study in 2017, that it's not probably an if, but a when in the correctional environment, that there are going to be foodborne illness outbreaks. Even if you have the best standards in place, the reality is some of these systems are feeding tens of thousands or potentially hundreds of thousands of individuals each and every day. And in our system in the Bureau of Prisons, we have approximately, I think, 144,000 inmates right now. And so we're at maybe 153 million meals a year. And so despite our best efforts, just because of the volume of the meals and based off the research in the past that shows, like, hey, these things happen in the environment that we work in more frequently really than anywhere else, we've really tried to take a proactive approach to not only increase steps in terms of prevention, but then also making sure that we are doing what we can to be prepared in case there is a foodborne illness outbreak. And so I think, going back to Sistine's presentation in terms of partnerships, that this is a step that I think a lot of folks might be able to take in working with individual jails, prisons, their state systems, to be proactive and find a way to have something in place. So if one of these outbreaks happens, that you have some guidance, you have something you're going off of, because these can throw systems into, individual jails, prisons, or systems into disarray really quick. if there is an outbreak. And so I just dropped it in the link before I started. We actually have a public document that we developed back in 2016 entitled Responding to Foodborne Illness Technical Guidance. And just before I start, this is specific. You'd heard the word silos before. There are a lot of those in the corrections environment, and so this guidance is Bureau Prison specific, but I think overarching application of it can be used in other environments as well, because we try to address. Well, I won't get ahead of myself here, but what this guidance provides is assistance with identification, communication, which is huge, and then response to these outbreaks as well. So we really have it kind of starting off with the collection of data when individuals start presenting with symptoms. And so we want to obviously start off with the health services staff who want to report this to the clinical director, the health service administrator, infection prevention control coordinator, to make sure that again, if there's kind of a cluster, that there's immediate notification of the key stakeholders within health services. Then we're going to want our health services administrator to start coordinating and communicating with the local executive staff, the warden, the associate wardens, to make sure they have situational awareness that we have something going on here. And then also our food service administrator, as health services working through seeing what's going on, if they did, to determine if there may be a foodborne illness outbreak, to let food service know that, hey, we've got something going on here. It may or may not be at this point a foodborne illness outbreak. And then we want them to really start collecting data. And that's really going back to especially the first presentation in this series. Something that's really pivotal is getting that data, systematically collecting it in terms of the housing assignments, work details, days, times of onsets of symptoms, because this is something in this environment that's really beneficial, because it might help narrow down the issue from where it could be potentially something that maybe an entire institution issue. If it was, they had a main line to where they all went through the same mainline food offerings, and potentially you had hundreds or thousands of individuals exposed. Or there's been a number of instances in the past to where it's really narrow, if you start looking at all the data in the housing units, to where it's a very small cluster of outbreaks within a specific housing unit. And then you can shift from maybe thinking, well, why is it just here? Is this something that was potentially consumed because of the inmates making something inappropriate that they might have stolen from food service, not maintained at appropriate temperatures, and made in their housing units? And so it really helps to identify potentially the scale of the issue, and where, again, the type of the cause of it. So that's really critically important, is having some standardized approach to developing a line list of, again, housing assignments, work, time of onset, and then those signs and symptoms for potentially identifying the pathogen, and then starting to develop a hypothesis. Again, trying to really figure out what it might be and where it potentially came from. Communications. This is something that's very challenging with any type of emergency response, is making sure that people are communicating succinctly and effectively to the appropriate people. And so at the institution level, in our agency, we have institutions, regional offices, and a central office. So we recommend that if we have something suspected for us, we want our regional or central office food service to be notified. And again, the local executive staff. With the outbreak investigation team, we want that formed with the executive staff, health services staff, food service staff, and environmental and safety compliance. And I'll get to some of what we're expecting of those positions in a moment here. Continuing to develop that outbreak report and collect data, starting to working on a plan for communications to not just the inmates, because staff, because if you look at the research on these outbreaks in the past, some of the literature out there shows that these outbreaks oftentimes affect staff members as well, who might have been eating at the staff dining and consuming some of the same items that the inmates were consuming. We want to start working and communicating with the local, state, and health facilities, reporting the outbreak, and then potentially determining if we can actually work with the local health departments to get lab samples. In terms of our health services staff and response, we want them clinically to, do steps in terms of preventing serious illness, checking hydration status, treating individuals, and considering isolation. We want consideration for staffing adjustments if there's sick staff members, specimen collection again if there's availability for testing, and then continued systematic updating of that line list, and starting to assist with the food history and interview of those individuals who have identified to have symptoms. With food service, we also have a number of responsibilities that they have as well. Again, we want them to be involved with the interviewing of their staff members, to include our inmate workers as well, and then increased emphasis on hand washing immediately. And then you can see here there's a number of different activities we want our food service administrator to be leading, which includes interviewing, again, the inmates, the staff, developing the flow chart, food flow chart and process guide, which is in that document in the link that I sent to. We've got some standardized forms in that link that we want them to be utilizing, making sure they're collecting the as served menu for the previous 72 hours, the recipes for the items on the menu, temperature logs, work detail history, and a number of other things here on the list, because these are all essential components that we want to make sure we're gathering the data on in kind of a standardized process. And lastly, within this guidance, some additional staff response in identifying specific roles. With the executive staff, we've identified that they're really responsible for ensuring the housing units have cleaning supplies, and the orderlies really increase the frequency of cleaning of the bathrooms and high touch surface areas, ongoing updates to staff, increasing communication to staff and inmates through town halls or memos. And then with our environmental and safety staff, really assisting food service with guidance on potential disinfection. And so what I don't have in the slides here today, a couple of other things, additional steps that we also take in the Bureau of Prisons, or have in the past, is we actually in the past have developed what we call the food asset support team that included a number of our food service administrators from around the country and some of our infection control coordinators from around the country that we had as a collateral duty that were part of this team, that if we did have a foodborne illness outbreak, that they were approved in this collateral duty role to be part of a kind of an emergency response team that, if requested and approved, could be deployed, if you will, to an institution to assist with medical staff, to assist with the food service staff with some of the items that we talk with there. So again, that's another step that we've taken in the past to be proactive, to have, again, extra hands on call in case we do have a foodborne illness outbreak. And with that team specifically, we've also done advanced training so that they are our medical staff have an increased understanding of specifically to foodborne illness outbreaks, and our food service staff have an increased understanding of the different types of pathogens and the epi that go along with the response. And so we've actually coordinated in the past through the Colorado Food Safety Center of Excellence and received specific training on foodborne illness response. Again, more advanced than what a typical food service administrator would receive, or a little bit more specialized in what some of our infection control folks would have received, so that they have a better grasp of the situation that they might find themselves in. And so again, the kind of my purpose today was I wanted to really make sure that folks were aware that from our perspective, that it's, we've approached this issue of foodborne illness, and specifically with outbreaks, is something that's very serious. We do everything we can to prevent outbreaks with the training of our staff, and aligning our practices with, again, the recently released guidance CDC put out years before the guidance actually came out. But again, being proactive and just anticipating that this is a potential that's out there, that there's a higher risk for it in this environment, and making sure we have some guidance in place for if that day comes, so that individuals within our systems know what their roles might be and responsibilities might be. And when we've developed, again, a number of documents in the appendix of that guidance to kind of help guide them through the process, because it's just not something that they would be familiar with or kind of know exactly how to walk through, because it is, a rare instance in most individuals' career. So with that, that's the end of my presentation. I appreciate the time. Thank you.
Great. Thank you, Captain Holiday. Thanks for going over the Bureau of Prisons foodborne outbreak guidance. And even though, as you mentioned, it's specific to the Bureau of Prisons, it seems like a really great resource that could be used for foodborne outbreaks across all carceral settings, and just a really good starting point. And so I want to thank all of our speakers today for their great presentations and sharing their expertise with us. And now I would like to open the floor up for questions. If you have any questions, please go ahead and add them to the Q&A box. I don't think we have any yet, but I do have a few of my own, so I can get started with that as folks start thinking about questions. But Sistine, you mentioned that I really you went over the siloed structure of the public health and the correctional settings, and some of the challenges in speaking to each other, and really emphasizing the need for being proactive and establishing relationships with correctional settings or correctional facilities before you need to go in and investigate outbreaks. I guess if an agency doesn't have a specific corrections or carceral liaison or epidemiologist, do you have any recommendations on who need to contact, or how to get your foot in the door and start building these relationships?
That's a very good question. And I've kind of thought about that, because I know that a lot of different health departments don't have that point of contact person yet, or they haven't designated someone to kind of be that liaison. I think there's lots of ways to kind of approach it. There are, of course, programs that already have kind of that communication, that might already be providing some services to a certain extent, or have had some communication, whether it's consistent or not. But I think maybe doing an inventory of, who is communicating already with the carceral facility in question. And, if you don't have a point of contact yet that already exists, then to designate someone. But if there are teams that are already working with these facilities, it's good to start there, because that sounds like that's work that's already, on both sides identified as priority pieces of work, right? Or priority projects to address public health issues in that setting. So I think starting there, and then, kind of building out that work and looking for opportunities to collaborate even more. But I think it's really important to listen to carceral facilities and the leadership there to say, what are your public health priorities? And identifying kind of which teams would best be the ones to kind of make that initial connection if there isn't kind of a centralized point of contact. I think that listening piece is going to be really important, because you can talk to them about, you can bring up any kind of priority item that's on public health's list, but I think you'll get more partnership if it's something that aligns with everybody on both sides. And I think that's important to keep in mind.
That's a really good point. Just trying to find like meeting at their level and leveraging like what they need to build that relationship really and get what you need from them for that. Yeah, thank you for that. And we do have a few other questions in the chat. So one, I think this is for you, Mitch, Captain Holiday. So where can we find other Bureau of Prison protocols for outbreak mitigation? I had the opportunity to use the scabies Bureau of Prison recently in my state. So just
Yeah, that's a good question. I can drop it in the chat because, and I almost did. So we have a number of our clinical practice or technical guidance available on bop.gov. And so I'll drop the link to that. There's probably, I don't know, maybe 30 plus different guidance documents that we have publicly available. And so, yeah, I'll drop that link in the chat. And then the one that I did put in the chat is one on that list. So, yep, I'll drop that in there right now.
that's another follow-up question. Can you provide more information on the specialized training provided to the food asset support team?
Yeah, I don't know, Amanda, you might be able to because you guys, I think of twice have done have hosted the or led the Epi Ready training for us. So you might be able to speak into more about this specific training, but yeah, it's the Epi Ready training, and we worked again with you guys out there in Colorado on it.
Yeah, and this is before my time, but I've heard a little bit about it. But the COEs do offer an Epi-Ready training that brings together epidemiologists, public health, epidemiologists, environmental health, and laboratory folks for it's a multi-day training that really uses a team-based approach to teach folks how to respond to a foodborne illness outbreak, and really just starts the lines of communication between all the different folks that are involved, and goes into all the disciplines and roles and responsibilities for each of the team members. And it is offered through the collaboration through the COEs. So each of our regional COEs offer that. So that's kind of what, yeah, that was what we did for.
And I found a link. I found a link and I dropped it in there as well, Amanda.
Oh, perfect. Thank you. It looks like there's a link to all the Bureau of Prisons resources in the chat as well, if anyone is interested in looking more at those. One more question. So are there any suggestions to build more local partnerships and communication between Bureau of Prisons and ICE facilities in the states where facilities are located? I'll open up to any of our SMEs.
This is an area that I had a question when I came into my role at the Department of Health, and I struggled because I tried calling the Bureau of Prisons, their numbers to ask questions, and you don't get a live person. You get a voicemail and no response after. So still trying and struggling maybe a little bit with the Bureau of Prisons. I know our person who does the tuberculosis, she went straight to the commander of ICE and was able to contact that person because there's a TB person in a prison who had actually been released and was in his country of origin by the time they got to somebody.
I'd say this is also, I think, like depending on the facility, a little challenging for us as well in Washington. But I think during the COVID response, we were able to like identify people we could check in with often, like at least get a name, get a contact, and like, obviously limitations with what we could do since it's federal jurisdiction within the facility. But I think we were able to kind of open up avenues in order to at least have communication to understand, what the situation for COVID was going on or, what was happening in the facility, and to get notified and to, at least communicate about how we were planning to respond to outbreaks in a facility when they occurred. I think another thing that we tried to do, especially in an emergency, was to just bring resources. And Luann, you put this in your slides, which I'm really grateful you did, was, we asked what you needed to these facilities. And, a couple times we were able to come to these federal facilities and bring testing supplies or offer vaccinations, or even just set up right outside and say, when you release people, we can, provide some resources or things like that. But it really does kind of stem back to like setting up that communication and trying to find those opportunities to collaborate where you can and bring resources. But yeah, I don't know, Mitchell, if on your end you have any suggestions too, I'd be curious.
Yeah. I think for me and I'll take it back to my specialty because I'm a dietitian by trade. But one of the things that I've seen done over the years is through the Academy of Nutrition and Dietetics and the Association of Correctional Food Service Affiliates, we do have groups of dietitians that work in corrections that have maintained listservs and that will email each other cross state, and like folks will kind of communicate that way. And even with that though, even with a small group of folks working in the same area, I've even found that we talked about before the silos, and these are environments where folks don't like to necessarily communicate what they're doing. So a lot of folks are pretty reserved because they don't want to. They might want to speak on behalf of the state or the entity that they're working for. So it can be challenging. But I know from our position in our central office, we are constantly working with individuals from advocacy groups, from responding to folks from states that reach out to interagency, like collaborating with CDC. So a big chunk of our roles in the positions that I have and some of the others I work with have is ensuring collaboration, not just within our system, but across systems. So sometimes it just depends on maybe who you're reaching out to, because if it is at the institution level, I think a lot of times you get folks that tend to be more reserved and not want to speak out of line or on behalf of their institution or the agency itself.
Thank you. We are at the hour, so just want to be mindful of everyone's time and wrap up. And just want to thank you all again one last time for sharing your valuable knowledge and expertise with us. And I'll put your email addresses in the chat if anyone thinks of any additional questions specific, and follow up with you via email. We also are sharing a link to the Integrated Food Safety COE website if you want to like to take a look at some of our free tools and resources that we offer, as well as a link to the Food Safety and Correctional Facilities registration page, which will house all of the recordings of the webinars, today's, as well as the webinars from the previous 2 webinars in a series. And there is a very short feedback form that will pop up when you exit the meeting. We use this information to help us identify topics and improve our future webinar series. So we'd really greatly appreciate if you could please take the time to fill this out. It's completely anonymous and should only take about a minute to complete. And thank you all for joining today's webinar, and hope you have a wonderful afternoon and great holiday season. And thank you again.
Thank you.
Thank you.